Howdy, y'all. This is Dr. Jarvis, and I want to thank you for joining us for another one of our videos for our community health paramedics. This one is primarily aimed at reducing readmissions for patients with COPD. And because of that, we have with us a pulmonary critical care doctor. Dr. Shah, thank you very much for joining us.
Of course. Great to be here.
If you don't mind, why don't we start off just by a little introduction. Where are you from? Who are you?
Sure.
How'd you get to be here?
My name's Shenil, Shah. I'm a pulmonary and critical care doctor here in town in Austin with Austin Pulmonary Consultants. I grew up in the Northeast, was born and raised in Jersey, and school and training was all up there in the Northeast, and just lots of family down here in Texas, and I was intrigued by the idea of living here in Austin, and that's what brought me here, and I've been pretty happy so far.
Outstanding. Well, welcome to Texas.
Thank you.
So tell us a little bit about what the training is to become a pulmonary critical care physician.
So long road. After 4 years of college, you have to go through 4 years of medical school, followed by 3 years of internal medicine, followed by 3 years of pulmonary and critical care fellowship.
Outstanding. Well, thank you very much for doing that.
Of course.
I appreciate your commitment to the community.
Of course.
Let's start off talking about COPD. If you can you just give us a sort of a 10,000-foot overview of what COPD is, what the pathophys is, if there are any distinctions?
So in patients who do not have COPD, our normal pathophysiology is for lungs to be able to expand and contract in. And that contracting in part of it, there's a specific enzyme that's very important for that called alpha-1 antitrypsin. What smoking cigarettes over a long period of time has done is it helps to decrease that enzyme level. So what happens in patients with COPD is that they certainly are able to expand their lungs out, but they don't really have the ability to squeeze their lungs and squeeze air out, and then that's kind of what leads to that lack of air movement in these patients. Furthermore, you do also get some destruction of your alveoli, and that's oftentimes what you might see as emphysematous changes on a CAT scan, or the blebs that they may refer to.
Do all patients who have COPD, do they all get it from smoking, or is there another way that you can end up with this disease?
I would say primarily yes.
Yeah.
I think COPD, really by definition is patients who have been smoking for a long period of time and have obstructive pathophysiology, which we can get to in a little bit, but you see that on spirometry.
Okay.
There are other medical conditions that can lead to obstructive lung disease, but COPD kind of specifically is
vast majority
in patients that smoke.
Let's talk about what the natural history of COPD is. So is this a disease that they come in, we give them a treatment, and they never have COPD again, or can we expect it to get worse throughout their life? How does that work?
Generally, the latter. Generally, it is something that should be expected to get worse over time, regardless of whether they keep smoking or not.
Okay.
And the reason behind that is in all patients and all people, our peak lung function is around age 35. After age 35, there's just
discouraging.
a slow. Yes, it is. So after that, there is a slow deterioration, as patients get older. So in COPD patients, even if they stop smoking, they already do have impaired lung function. So you do expect that lung function to deteriorate over time. Now, things aren't set in stone with certain inhalers, stopping smoking, certain medication regimens, their exercise activity. You may see a small improvement, but we will never be able to get someone back to 100% lung function.
How about getting, say, a 50-year-old back to 35-year-old lungs?
It would be tough. It would be tough.
It was worth a shot. So we're seeing a patient at home. Anything we can use to help determine or describe to you how a patient is doing to help you make a decision on what we need to do with them?
Yeah, so I think in terms of trying to figure out a baseline, I think something objective is certainly very good.
One of the ways that we determine that is with blood work. We look for bicarb levels. We don't have that in the field, but we do have end-tidal CO2. Is there much of a role? What sort of things should we expect to see?
I think so. I think checking end-tidal CO2 can be a quick, easy way to see if someone is having CO2 retention. And so, I agree. I think that's a great tool because otherwise you really don't have anything else. You can certainly get an ABG, but again, that's blood work. So this is kind of a quicker way to go about it. With COPD patients, as I kind of referenced, oxygen levels are very important. What is their last baseline? And if they're on 2 liters and they're up to 8 liters, they're obviously certainly far off. Especially for someone that's seen in our clinic, we oftentimes get spirometries on these patients. And so what is their FEV1 number? And that's a big number.
Okay.
What was the last FEV1 number? That's an indication of how severe their disease was at that time. And so that's certainly a big thing. What is their exertional ability like? In clinic, we monitor that, we call it a 6-minute walk test. So literally over 6 minutes, how far can they walk? And then, of course, what is their mental status like, too, which becomes very important. Certain patients who retain CO2, which we'll probably talk about in a little bit.
And you had mentioned that there's a ratio of expected to observed. Mm-hmm. So when you were talking earlier about they come in, they do the spirometry, and they get 50%. Is that a score that's actually represented on the spirometry, or is that something they calculate?
It's done on the spirometry. What is predicted, you might say, well, this patient, we would predict based on their age, their gender, ethnicity, and height, that they should be able to breathe out 4 liters of air in 1 second, and they may do 2 liters. And so that 2 over 4 is that 50%.
What does the device look like, and is this a portable thing? How would you instruct a patient to do it? How would you actually walk through taking that measurement?
Yeah. So there's many different ways to get this.
The doohickeys are different?
Yeah, exactly. And so in certain big PFT labs, for example, there might be a big body box, which is where a patient literally steps into the box and they breathe in and out. And other times there's just a little plastic device that they breathe in and out of, and that determines that part of it. There are portable ones, which certainly may be of use, when you're out in the field, for sure.
So if our medics are out seeing one of your patients and they see a clinical deterioration, they're not yet at a definitely sick, need to go to the hospital stage, but they wanted to give you some increased information. Would an FEV1 be useful for you?
I think absolutely.
Okay.
I think it gives everyone an idea of what their lung function is like at this time. And then certainly if I'm on the phone with someone that's taking care of my patient, for example, I can look up what the last FEV1 was. Their baseline is 50%, and it's down to 30%. And that's a red flag that, hey, they're quite impaired.
Do any patients have their own spirometry and trend these numbers?
Not really.
Okay. That's pretty much an us thing.
That's pretty much a medical personnel thing.
Talk about what you use in the clinic, what you use in the hospital, and then if there's anything that we might be able to get in the field that would be useful.
In our clinic, for example, we would do a spirometry. We would do lung volumes, which assesses how much lung is in the air. We can check for things like air trapping, which you can see when patients are not breathing out, is air being retained, as well as their diffusion, which is just how well carbon monoxide diffuses from their lungs into their blood. So these are just some of the things that we would test for in the clinic. Obviously, you can't do that from a portable setting. Hospitals also do have PFT labs generally, but in terms of patients that are hospitalized, oftentimes we do sometimes get a spirometry that's done at the bedside. And that can help, especially if someone's never been seen by a pulmonologist and they're coming in with this level of exacerbation. We don't know anything about them, and then those numbers can really help you big time to determine, well, how severe is their lung disease and what do we need to do. And so, I guess now that I'm talking about spirometry, maybe I'll just talk about the diagnosis of COPD.
Sure.
And as I mentioned earlier, that you do have to have obstructive lung disease. And so, what that is on the spirometry, you check a few things, one of them being your FEV1 number. And so what that number is how much air you're able to breathe out in 1 second. Your FVC is how much air you're able to breathe out in total. And based on patient's age, their gender, ethnicity, their height, we predict a certain amount. And then it'll give the actual value, and you can determine a percentage out of that.
Okay.
And so, without getting too complicated, but basically your FEV1 over your FVC, if that ratio is less than 70%, that's indicative of obstructive lung disease. Clinically, what that means is that patient is breathing out very slowly, and that's very characteristic of COPD patients or other patients that have obstructive lung disease as well. So the first thing to really get them to a diagnosis of COPD in a patient that has smoked cigarettes for a long period of time is to diagnose them with obstructive lung disease. But then you want to determine what is their severity. And at that point, the number of the obstruction, that ratio doesn't matter so much as the percentage of the FEV1. And so the numbers to keep in mind, now there are a couple different criteria. The GOLD criteria is one that's pretty popular, and the numbers to remember are 80, 50, and 30. So an FEV1 number between 100 to 80 is stage 1 or mild. Stage 2 is 80 to 50 or moderate. Stage 3 severe is 50 to 30. and then anything below 30 is considered very severe or stage 4.
Let's talk about how we treat these patients.
A good way to break it down is breaking it up into acute medications or medications for acute care and kind of more long-term therapy. Your acute therapies are more geared for patients that are having COPD exacerbations, or just they're walking and they get a sudden episode of shortness of breath or wheezing. Some of these medications are Albuterol, Ipratropium, which is a short-acting anticholinergic. Albuterol being a short-acting beta agonist, and then there's combinations of those, such as Duonebs, and they come in different forms, inhalers and nebulizer form.
Perfect.
And then there's the long-term medications. Really, the one that's really been shown to have the best benefit in patients are anticholinergic medications or long-acting muscarinic agents. One very popular example of this is Spiriva, and that's kind of been a big mainstay. And they looked at studies on this, comparing them to other classes, and they really found that patients did the best on this medication. Other medications, inhaled corticosteroids, there's long-acting beta agonists. A lot of times there's combinations of those two, popular one being Advair or Symbicort. What we have seen a lot of times is in patients with COPD, they tend to have some kind of reactive airway disease as well, like asthma. So a lot of patients do benefit from those medications as well. Okay. And then, of course, you've got steroids, right, which are generally used for acute exacerbations, but in some patients who have just such poor lung function, you do find them on low doses of steroids at baseline.
What's the role for antibiotics in the COPD patient?
There's still a role. They've looked at a few studies on this in patients who, as you mentioned, really no signs of any active infection, but they do seem to be having a COPD exacerbation. And they looked at various antibiotics. The one that they really found, the class of medications that really seemed to help was macrolides. One of the really common ones being azithromycin. And they found that patients who received azithromycin and who did not, patients with azithromycin did seem to do better. Their frequency for hospital exacerbations was less, quality of life was better. It really was beneficial. Part of it could be, I know azithromycin has been talked a lot about having some anti-inflammatory effect. Maybe that's it, but I'm not sure we know exactly what it is. But COPD patients do better with antibiotics.
What is the role for anxiolytics, particularly benzodiazepines, for these patients?
Yeah, I think certainly in a certain subset of patients which just do have a lot of anxiety, those anxiety attacks just do not help from a respiratory standpoint. And what you don't want is that to trigger respiratory failure. And so I think in that subset of patients, it does help to administer an anxiolytic. But I really, at the same time, anxiolytics are sedatives, and they can suppress respiratory drive as it is. So it's kind of between a rock and a hard place there. Yeah. So you really do have to kind of look at the situation. And if you think this patient is going to go into respiratory failure if they don't calm down, then that's probably a perfect time to give it. And unfortunately, that's a subjective thing. Yeah. There's no objective numbers to say this is the time to give it to someone.
I think frequently with EMS, we actually have this a little bit easier because we're not having to think about prescribing these. So we're going to be there with the patient. And if worse comes to worse and we give a patient 2 or 3 milligrams of Versed and their respiratory rate gets worse, that's all right. We can just look at that as the first stage of our intubation process. Sure. So what are the treatments that have been shown to decrease mortality?
So I think azithromycin is one of them, where not only have we shown decreased hospitalizations, but it has shown a trend towards decreased mortality. Long-acting muscarinic agents, so going out of the antibiotic realm, have also been shown to help decrease some of that. Physical exertion, staying very active, while it has not actually shown a mortality benefit, I can't imagine it doesn't.
Certainly for morbidity.
It may be one of those things, maybe we just haven't looked at it enough in detail. So things like pulmonary rehab do end up being very important for these patients.
Since you didn't mention oxygen therapy as decreasing mortality, does that help with morbidity?
It does. It does for sure. I think certainly in those patients that are quite hypoxic, that have very severe COPD, oxygen certainly has improved morbidity. Certainly in patients who have very poor functional capacity, and if you look at their lung imaging, you might see that they have very upper airway predominant disease. Okay. In these patients, there is something newer that came out just in the last probably decade or so called lung volume reduction surgery. In these patients, they get surgery where they literally get a resection of the upper parts of their lungs. The idea there being that the rest of the lungs expand. In these patients, they have found a significant improvement in morbidity.
So let's talk about some of the side effects of these medications. primarily the one that jumps to mind are the steroids. So if you have a patient who has to be on long-term steroids, say they're on 10 or 20 of prednisone just from now on, what types of things should we be watching out for?
The biggest things, weight gain with steroids. It can raise patients' blood pressures. It can raise their glucose levels. Certainly, patients sometimes don't tolerate them. If they're on long-term, you would think they probably have kind of gotten over some of that, but some of those side effects can be inability to sleep. They're very irritable. It certainly can change their mental state a little bit. Another side effect you do see is kind of weakening the bones or maybe making them more prone to osteoporosis.
And I'm assuming then those side effects from steroids, are those less prevalent with the inhaled corticosteroids or as opposed to the orals?
Yeah, absolutely. Inhaled corticosteroids, they really have not been shown to have any of these side effects. They really are kind of limited to the airway. Yeah. One thing that's out in the literature as a side effect of inhaled corticosteroids is increased higher risk of pneumonia. Inhaled corticosteroids, you do get oral thrush, and so it is very important that these patients rinse after they use one of these.
Thrush, you get this white goop in your oropharynx. It's important that we instruct our patients that you've already told them this, but patients sometimes need to hear things multiple times. Right. Reiterate the flush afterwards.
Sure.
Can you talk a little bit about what goes into your decision-making as to when to send a patient home? It's
a challenging thing for sure because they're here in the hospital, and the hospital is great for treating certain acute conditions. And obviously for IV antibiotics or IV steroids, if that's what they need, certainly great for those settings. But what happens here in the hospital is patients sleep for 8 hours, and primarily during the day, outside of the maybe 1 hour they're with physical therapists, they're in bed, which isn't really good for their lungs. They do need to be very physically active. So it is a challenge. And so some of the things I do look at, what is their respiratory exam like? Are they wheezing on exam? Are they moving air well? Are there other comorbid conditions affecting their breathing? So are they fluid overloaded, for example? I look at their oxygen levels. In patients that have COPD, say, for example, a patient is on a baseline of 2 liters of oxygen, and they're on 8, well, that's certainly a sign that they're far from their baseline, that we need to do a little bit more before we can get them home. And then what is their exertion level like? So I rely a lot on physical therapist assessments. If patients are saying, or physical therapists are saying that patients are walking around the unit several times and their exertional capabilities are pretty good and their oxygen levels are close to baseline and they're not wheezing, I think that's a patient that's probably okay to leave the hospital setting.
What sort of symptoms or physical findings we would see for patients that in one group are doing fine and we don't really need to do anything else other than maybe social care. 2, they're doing a little bit worse than baseline, but we can do some things at home to prevent them from having to come to the hospital earlier. And then finally, the patients that we need to say, look, we just need to get back into the emergency department.
Well, I think the first group, these are probably patients who maybe are a bit more short of breath. Their oxygen levels are probably just at their baseline. If they're not on any oxygen, their saturations are fine. Maybe they're wheezing a little bit, maybe not even having much in terms of fevers or chills. And these patients can probably be treated with conservative measures at home. Plus or minus, you could maybe prescribe an antibiotic course or steroids depending on what their symptoms are like. But these patients are probably the kinds that can probably be treated conservatively.
Okay.
The patients who probably need a little bit more intensified therapy at home is the patients that maybe oxygen levels are a little higher, they're febrile, they just don't sound very good maybe on exam, but they're stable. Their mental status is normal, and they don't really look like they're an extremist by any means. Okay. And these patients probably definitely need steroids or antibiotics. Or maybe nebulizer treatments. And then finally, the patients that really need to go to the hospital. These are the patients that are really struggling for taking a single breath in. Keep an eye on mental status. That's a big thing with these patients with COPD. As I mentioned earlier, these patients have a hard time breathing out. And when that happens, our CO2 levels tend to go high. And it doesn't suddenly just go normal mental status to completely unresponsive. Sometimes, it's absolutely a continuum, and oftentimes I hear it from family members. Spouse will say, he's breathing okay, but his mental status is just a little bit off. He's a little bit confused, and that could be a red flag that, hey, maybe there's something going on.
Yeah, a little goofy.
And so those patients, if you do notice that there are mental status changes, they certainly would have to be put on a BiPAP mask and probably should be in the hospital setting.
So if I can reiterate that, then the 3 groups, The patients who are doing all right, we don't really need to do anything else. They would be at their baseline pulse ox, their baseline oxygen demand. In other words, the liter flow is the same as it is, and their exertional tolerance is about the same. They may have a little bit of wheezing, but they sort of always have a little bit of wheezing, no worse than usual. And then the patients who can probably still stay at home, but we may need to call for a consult to change their home therapy, or ones that may have a fever. Certainly if they have a fever, if they have an increased oxygen demand or a decreased exercise tolerance. But they're still mentating well. They can still have a decent conversation without assuming that they ever can have a decent conversation. And then the group that we really need to do something with, the thing to look for there is hypoxia worse than where they normally are. If they live at 90%, then they're probably not going to get much better. But now if they're down in the 70s, 80s, or if they have some type of encephalopathy, changed mental status, look out for.
And I think also just examining a patient and just seeing them in extremis. Maybe their SATs are okay, or maybe their mental status is okay, but in those patients, they may still benefit from just being checked out in the hospital.
Sort of the gestalt, the spidey sense.
For sure.
Perfect. I love the great effort that a lot of academics, myself included, go through to try and come up with rules, and none of them beat clinical gestalt.
Absolutely, yeah.
What are the requirements for a patient to get oxygen at home?
So your oxygen saturation has to drop below 88%. At least that's the last time I checked. And certainly these requirements have changed here and there. But you do have to document that the patient does desaturate below that amount for insurance to cover any supplemental oxygen. And
does that have to be at rest, or can we provoke that?
We can. And so if patients are walking, and so oftentimes we'll do walking tests, not only in our office, but even in the hospital setting. Someone may be on 2 or 3 liters and you just can't get them off of that oxygen requirement. Oftentimes we walk patients in the hospital setting. You'll see the nurses or physical therapists walk patients, and if they fall below that, then there's a clear need for it, and insurance really should cover it.
What is pulmonary rehab? What would the patient expect? What types of things can we tell the patient to look for? And then you already mentioned the benefit of it. So what is pulmonary rehab?
So pulmonary rehab, very underutilized therapy that is available to really a lot of patients with COPD. Think of it along the lines of a gym. There's a lot of gym equipment that includes cardio and strength training. Generally, it is run by respiratory therapists, and then there's oxygen hookups along the walls. Usually insurances all have different requirements, but like, for example, Medicare will say, well, we'll cover, say, 20 visits. And the patient can schedule that however they want. They could do one visit every 20 weeks, one visit for 20 weeks, or maybe 2 or 3 visits for 8 weeks, whatever's convenient for them. What is done at these centers is that they are pushed really onto their limit of being very physically active, and just that physical exertion itself is very beneficial to patients. It strengthens the respiratory muscles. It helps to move air much better. It gives them more energy. I've never had a patient that has not loved pulmonary rehab. They come back happier, better lung function, which we even see on spirometry, and their quality of life is significantly improved. So it's definitely very beneficial.
Perfect. Well, I'm a runner, and I found that physical exertion is probably one of the best antidepressants around. I can't imagine if I had COPD, I think that would be a pretty depressing thing.
Absolutely.
So get engaged.
Right. And I should mention the other thing that they also do at these centers is they'll teach patients how to breathe when you're exerting yourself. And there's certain ways to alter your breathing that can help out a little bit.
What types of things do you tell patients on discharge or when you first diagnose them that can help their disease process?
I think staying physically active. You're probably going to notice a trend from me in terms of what I usually recommend. I mean, I think it's kind of underappreciated how much physical exertion helps, obviously for all medical conditions and all well-being, but especially in respiratory conditions like COPD, where physical exertion strengthens your respiratory muscles. It makes it easier to breathe on any limited exertion. It helps to move air well. Hospitalized patients, it's very common to find something called atelectasis, which is also, in layman's terms, lung collapse. And that's just as simple as whenever someone's in bed for a while, your lungs tend to do that, and you're blocking off air movement in those areas. And so when you're staying physically active, you're opening those back up again, and you're really using all of your lungs. It's also underappreciated, the effect of weight gain on breathing. And certainly in this country where we have such a high obesity level, it really takes a big toll on patients, especially in patients that have impaired lungs already, like in COPD patients. If they have an extra 20 pounds of weight on their chest, it really is like breathing out against a 20-pound dumbbell, and it can be very difficult. And so I think the more active they are, they will be able to keep a little slimmer weight, which helps them tremendously.
One of the things that got that home to me so quickly was seeing chest X-rays of morbidly obese patients.
Sure.
You see this massive, as a matter of fact, we'll put up a picture. Look at the picture of the morbidly obese chest.
Yeah,
wow,
you're right.
That's great. You see that the lungs don't get bigger.
Right.
So they're still having to do the work of all this extra tissue
Sure.
with a lead weight on them. Yeah,
Right.
That's an important point. Are there any dietary restrictions or advice that you give patients?
I think just in general, a healthy diet, and that's kind of a broad thing, but basically watching their caloric intake. Certainly doesn't apply as much to some of the COPD patients who are extremely skinny.
Right.
And a lot of patients who are overweight, certainly just trying to limit their caloric intake.
So if we're going to talk about things that COPD patients can do for themselves, my God, there's a large elephant in this room. Telling them to stop smoking. I'm sure you've told some patients to stop smoking once or twice. That can be a real challenge. Sometimes there's some defensiveness built up. I'm pretty sure that we're not the first person to tell them they should stop smoking. Do you have any tips or tricks on how to broach the subject or reinforce what other people have told them?
Acknowledging the fact that it is extremely difficult. You know, people have been smoking for a long period of time, and there are receptors in our body that are receptive to smoking, and so they know what I'm going to say when they come to a pulmonologist's office. But I'll start off just by saying, you know, I know this is difficult, and it's much easier said than done. But we do need to get you off cigarettes, and the reason for that is this, and at least in my experience, when I've brought it up that way, no one has been very confrontational about it. They've always been receptive, and patients all know it. Everyone knows that cigarettes are not helpful, and so usually they'll say, yes, I know, I've been trying, and usually that's the response I get. And then at that point, I'll recommend, and I'll say, well, there's different therapies out there that can assist you in this, and some of those medications are Chantix or nicotine patches or nicotine gum. But what I do oftentimes tell them, and there's a recent study, maybe just in the last 2 or 3 years that came out, that looked at who had the highest success rate. The patients who were just strong-willed, that decided, hey, here's my end date and I'm going to stop, or the patients who were on Chantix or any of these other medications. And they found the patients that were just decided, strong-willed, without any assistance, they were the ones that actually had a higher rate of coming off of cigarettes. So I oftentimes do tell them that, where if they're not picking a date and they're not 100% on this, I don't think nicotine patches and nicotine gum is really going to tip them over. So I say, listen, pick a date, tell me when it is, and if you want some help from me, I'll be happy to make that happen.
Tell us what the role for vaccinations. Are there particularly any vaccinations that can help this patient population?
Yeah, I mean, I think 2 in particular come to mind. There's the influenza vaccination, as well as the Pneumovax. And influenza is one of those, as we all know, is every year. Really, for a lot of people, it's beneficial, but in COPD patients, if they really do get that strand of flu that could have been prevented, I mean, it can really take a big toll on them when their lungs are already impaired. And then Pneumovax being where it helps against the pneumococcal disease.
How often do they need to get those?
Yeah, and then this is where guidelines have changed a little bit. Influenza's every year, but Pneumovax for a while was anyone who has COPD or even asthmatic patients, or really a lot of respiratory conditions, you get it once before the age of 60, and then you have to get it one more time after age 65. But I will tell you, these guidelines have changed quite a bit, so it may even be different right now.
Some of the questions our CHP folks have asked, they have come across a lot of patients who on discharge are given nebulizers and they're told to use it on a scheduled basis. But when they go see the patients, either nebulizers or inhalers, and when they go to see the patients and ask the patients what they're actually doing, they're told they're only using them as needed. Is that something that is sort of an expected, that they'll transition from scheduled to as needed on their own, or do we really need to be reinforcing do it as prescribed?
I think as prescribed, certainly, and I think that decision of whether they should be on standing nebs or just as needed is really kind of a case-by-case basis. The patient who has fairly stable COPD, not going in and out of the hospital, not having frequent exacerbations, they're probably okay with just as needed therapy. But the patients who are in and out of the hospital, their COPD is not under very good control, maybe they're stage 4 disease, those patients probably should be on standing nebs.
Do you find that there is a difference in efficacy between inhalers, properly used inhalers, let me give you that, and nebulizers?
So the inhalers, I think the big issue, as you mentioned, is the proper technique of it, and I think a lot of patients do have an issue with that. A lot of patients will just press the puffer and then breathe in and really end up just swallowing it. And so I think that's the big issue with that. nebulizers kind of take some of that away.
Okay.
And so I think for that reason, I think nebulizers overall do have better efficacy. But in a patient who's taking, who's using inhalers properly, probably not much of an effect. Part of it could also just be a placebo effect too, where patients think that nebulizers are helping them a lot more.
The magic gas.
Yeah, exactly.
Yeah. Yeah, we talk about like banana bags for alcoholic patients. The literature says it has no value.
Right.
There's something therapeutic about the yellow.
Right.
I think that helps. It seems like I've seen a correlation between patients with a lot of blebs and spontaneous pneumothoraces.
Yes. So, I mean, if there is any rupture to any of those blebs, suddenly you have a big pneumothorax. Because keep in mind, those blebs incorporate a bigger space than, say, just one alveoli. And so if there is any kind of rupture to that, it's a sudden pneumothorax. So certainly those patients are very high risk for that.
There are obviously also some changes to the cilia in your upper respiratory tract. I've had a lot of patients who I see in the emergency department who complain that their cough actually gets worse after they've stopped smoking for a short period of time. Is that something that we should tell people to expect when they stop smoking?
I've seen it here and there in certain patients. I can't say that I have a great explanation for why that all of a sudden happens. Certainly, I think part of it is that patients have smoked for a long period of time. It works on certain receptors, and so patients have gotten used to it. And so part of it could just be the withdrawal part of it. They feel worse, their energy levels are lower, and so that may be a part of that whole syndrome where they're kind of almost in withdrawal. Something
we should tell them it's worth to just
push
through?
I think just to, certainly push through it. Yeah. Certainly there are medications out there that can help them through some of those withdrawal symptoms, nicotine patches, nicotine gum, things like that.
Sure.
But yeah, certainly something to worth mentioning to these patients.
One patient population we're seeing more of is patients with pulmonary hypertension. Can you tell us a little bit about what pulmonary hypertension is, who is prone to get it, and what some of the signs and symptoms are?
So pulmonary hypertension is a big class is a big diagnosis. And all that really means is that your pulmonary arteries are enlarged. And oftentimes you might see a CAT scan report or an echo report that might suggest that. Really the diagnostic criteria, the real way to address that is to get a right heart catheterization. But in terms of what causes pulmonary hypertension, there's a lot of different classes. And so you kind of have your class 1, which is your pulmonary arterial hypertension. This is your kind of idiopathic, sometimes usually genetic diseases. Class 2 is your cardiac induced, so typically left heart disease that has led to higher pressure amounts. Class 3 is pulmonary induced, so your bad COPD patients that have bad pulmonary fibrosis, sarcoidosis, things like that. Stage 4 is chronic thromboembolic pulmonary hypertension, so these are the patients that just have chronic pulmonary emboli. And then your class 5 really is just a mix of a lot of different diseases altogether. It's hard to classify all pulmonary hypertension patients the same. It's really, in those cases, it's very important to figure out what the primary cause is, and that's where the right heart catheterization kind of helps, and you can get different pressures from different parts of the circulatory system, and that can point you towards one disease versus the other. Of course, in these patients, if you already know someone has COPD, not that it's not possible to have another cause for it,
does make it more
It certainly is possible. It's certainly if someone is stage 4 on chronic oxygen, it certainly is very possible that it's because of that.
It's kind of quacking like a duck.
Exactly.
Walking like a duck.
So no contraindications necessarily that I can think of. I mean, if someone's in an urgent situation, nothing that I can think of that would say, well, don't give this medication because they have pulmonary hypertension. And a lot of times you might see that might be a diagnosis carried over from an echocardiogram or a CAT scan, and oftentimes they've gotten a right heart catheterization and their pressures are actually okay.
Sort of an incidentaloma that's that we shouldn't be chasing.
Right. Something to be aware of, and something that may need more workup. But in the field, certainly nothing you're going to be able to do at that point.
Okay. But can you give us an idea when you decide to intubate patients with COPD?
Certainly, if their oxygen levels are extremely low, for example, and no matter what you've done, you've put them on high flow oxygen, you've maybe tried pressured therapy, like say BiPAP, for example, or you've tried all these things, and the oxygen levels have only come up a little bit. I think in those cases, all you really have at that point is intubation.
Okay.
I think in the patients who are, they have high CO2 levels, and you've tried BiPAP, and they're just completely obtunded, and you're really worried that they're not going to be able to protect their airway. I think in those patients for sure it's important to intubate them. mental status, that protecting the airway part of it does become very important as well. So, yeah.
So it sounds like there's a hypoxic reason, a hypercapnic reason, and then the one we typically think about with trauma is an airway protection.
Right.
If you go back to like the Manny Rivers study, the early goal-directed therapy, he actually had intubation and paralysis and ventilation in there as essentially an energy conservation, realizing we're kind of moving away from COPD and going more towards sepsis or severe illness. What do you think about using intubation as a way of helping patients conserve energy to use it elsewhere?
I don't know so much in terms of conserving energy as it is their inability, their own lung function at the current time, and having the inability to properly oxygenate, protect their airway. And so I think of it more in that terms, where they are just not able to do it.
We have, by nature, both in EMS and in the emergency department, a very, you could probably say, short-sighted view of what happens to the patients. We take care of them in the field and make them my problem in the emergency department. I take care of them in the emergency department and then promptly make them your problem. And for both of us, the quicker we can do that, the better.
Right.
That's not really an option for you. You have to make them better. What are some of the downstream consequences of us intubating these asthmatic and COPD patients?
One of the big things is, as we kind of talked about very early on, is patients that have emphysematous changes. They are very prone to pneumothoraces. So if you are going to be giving very high positive pressure, that really does increase the risk of it. Of course, you have to weigh the benefits and risks, just like everything else in medicine. If their SATs are in the 40s, you do what you have to do. But that can certainly be one thing to watch out for, especially in patients that have very severe disease. And the other thing is they can be a little bit difficult to manage on the ventilator too. We all have an inspiratory to expiratory ratio. Typically, we all breathe at about 1 to 2. COPD patients are typically around 1 to 3, but I have seen it as high as 1 to 10. So they breathe very slow and very prolonged. And so it can be a little bit difficult on the ventilator if you just put them on 1 to 2 or 1 to 3 ratio. Right. You really have to try to match what they physiologically do, and that can be a challenge.
If we have a patient that looks like a COPD exacerbation, as a matter of fact, I'll just say God reached down and said this is a COPD exacerbation. But for whatever reason, we have to intubate them. As we're intubating them, we get their SATs up by all the other means we do. We do our DSI process. It works great. They have no desaturations. We get them successfully intubated. There's no doubt the tube is in the right place. They had a great blood pressure going into this process, and about 1 minute, 2 minutes after the intubation, they become hypotensive. Can you walk us through the troubleshooting of what might have happened and what types of things we can do?
Yeah, this is something we encounter a lot of, really in all patients, and a lot of it is the anesthesia. Whatever the sedative used was, for example, say propofol. It does lead to hypotension, and a lot of times that does come up after a few minutes. Sometimes it can take longer. The other thing to consider in COPD patients is, did they have a bad pneumothorax? And that's a big red flag. That's something. Are they moving air? Do you hear breath sounds, especially at the apices? And if you hear good breath sounds, that's probably not the case. But if someone does have a massive pneumothorax, we'll call it a tension pneumothorax, that can cause hypotension. But more often than not, it's probably the anesthesia effects. And that's one of those things where you can wait and see if it comes back up again. But if it doesn't, then they may need to be started on some pressor medications.
You intubate somebody, they become hypotensive, you hear no lung sounds, probably have a pretty low threshold for doing a chest start. They're trying to relieve the tension. What about the role of breath stacking, if you think they're breath stacking?
And that's where...
Or if you're doing it to them.
Right. No, that's an important thing. And breath stacking can certainly lead to a lot of the same things, where your cardiac return is going to be decreased, and that can lead to hypotension. And that's where, if you're doing it to them, you need to space it out a lot more. Instead of however many breaths per minute, you got to just slow it down quite a bit. Sometimes it can be 6 breaths or 10 breaths max in a minute. Other times, like say someone's on the ventilator, adjusting those settings and basically trying to find a way for the ventilator to provide the breathing that is at their baseline.
We have a tendency, no matter how much we know we shouldn't be doing this, and no matter how much we try not to do it, we have a tendency to hyperventilate patients. It seems like this is a group that's particularly bad in. Okay.
Absolutely.
Sometimes I found that I have to actually just unhook the patient from the circuit, sit on my hands a little bit, and as long as their sats aren't dropping, just give them some time to exhale.
Absolutely.
Let's say that you are working a code, you have family members there. How do you approach talking to the family?
Tough conversation. I will explain to them everything that we've been doing so far. What is their current medical condition? It's a little bit difficult to have these conversations during CPR itself, but say they're overall just not doing very well, or maybe they've been resuscitated and we're talking about hypothermia protocol or some of those things. I'll explain to them, this is where we are right now. I'll be perfectly honest and say I don't know how things are going to go at this point. Family members, they're having a very hard time with this decision because they feel like they're making a decision for their loved one.
Right.
What I try to say, and I don't know if it actually helps or not, but in reality, they're making a decision on behalf of their loved one. If there is a living will or they've spoken about these things, that makes it that much easier for family members, but sometimes they have to go based on what they think this person would say in that situation. And so what I usually say is that, everyone has different choices, everyone has different wishes. Some people want everything done. I will outline what everything is, where it means, okay, you're going to be back on the ventilator again, and if you're not able to come off the ventilator, what is the next step? And then I'll explain what the opposite is, where people just decide, hey, you know what, we've gotten to this point, I don't want to do any more, I don't want any more labs, I don't want any more resuscitation, I don't want to be on the ventilator anymore, and that's more comfort care, palliative care, or hospice. And then how there's a big in-between. And I'll outline for family members what that all looks like. And based on that information, they're usually able to make a decision as to at least what they want us to do. Okay,
very good. I think one of the things that you said is really important. I try to do this in my practice, primarily because of my experiences seeing my parents struggle with making these decisions for my grandparents. My family felt a great deal of guilt in saying, no, stop, don't intubate, don't do this. Even though my grandparents had no hesitancy at all. They were very clear on what they wanted. So what I try to emphasize is exactly what you were saying, that I'm not asking for your opinion or your decision. I'm asking you to be a surrogate for them. What would they say if they could speak for themselves?
And the other thing to keep in mind also is, say it's a patient's son, for example, or a daughter. They may say, you know what, my father would not want this. I don't want this to happen. I don't want it to go with aggressive care, especially if there's no chance of recovery. But a lot of times people are worried about what they're going to be looked at as by other family members. So are other family members going to look at them and say, you made this decision, why did you make that decision? It's a very stressful thing. And so that's where I do try to speak to as many family members at once as I can, explain to all of them what the situation is like.
That's a very good point. And that's also probably a pretty good place to end it. The end of life, end of conversation. Well, Dr. Shah, thank you very much for the conversation. I really appreciate it.
Yeah, thank you for having me.